Thank you so much, Dr. Ahmed Tak, for this elegant presentation. You are a dear colleague of mine, and we knew each other for long years, and we've been very dear colleagues. And I think we finished our thesis together. I think our MD thesis together. We have a long history together. Thank you so much for the introduction, and I'm very proud of you and what you've established too. You are a very eminent electrophysiologist as well. It's very difficult to present a case after the wonderful cases that were presented by Dr. Mohammed Magdi. I will try to present my humble case. It's only one case, it's not a collection of cases, and it was a very interesting one. We did it, I think, 2 months ago, I think. It's a non-CTI dependent atrial flutter ablation case. It's very interesting, and it was the first time for me to ablate this kind of atrial flutter. Our patient is a 66-year-old male patient who is hypertensive, and he started to complain of palpitation 3 months ago. At the beginning, it was sudden onset, and it was paroxysmal, and with time, the paroxysmal attacks became more and more long, and by the time we saw him, his tachycardia was incessant. Once he started to complain of the palpitation, he sought medical advice where he lived. He lived in the Gulf area, I think, and he sought medical advice, and he was diagnosed with atrial fibrillation, and he was prescribed a collection of drugs like amiodarone, bisoprolol, and rivaroxaban. And he stayed on these antiarrhythmic drugs or these medications for quite some time, but he remained severely symptomatic. And when he went back for reevaluation, his treating physician saw side effects of these antiarrhythmic drugs. He started to experience sinus bradycardia, which was completely, I think, asymptomatic. And his ECGs during the intervals of sinus rhythm showed also Mobitz type 1, AV block, and first-degree heart block. So surprisingly, his treating physician advised him to implant a DDD pacemaker to try to continue on antiarrhythmic drugs or to increase his antiarrhythmic medications. After taking this consultation, the patient sought another medical advice, and he came to us. And when we revised his history and his investigation, this is his resting ECG during the occasional episodes of sinus rhythm that was done back a few months ago. But when we saw him for the first time, he was in incessant atrial tachycardia or incessant tachycardia. That ECG showed well-controlled ventricular rate with first-degree heart block. Otherwise, there's nothing abnormal in this ECG. This was the ECG of his tachycardia that showed atrial tachycardia with a regular monomorphic P waves, and the atrial rate is about 250 to 300 beats per minute. So it indicates this might be an atrial flutter. And what was characteristic about this atrial flutter, that it looks like it's not a typical atrial flutter. Of course, it's not a CTI dependent. It looks at the atypical. There was a distinctive monomorphic positive flutter waves in V1, but the rest of the leads, the flutter waves, were all almost isoelectric or flat flutter waves. The only flutter waves that were apparent are only in V1. Okay, so now we're faced with a patient with incessant tachycardia that is atrial tachycardia, atrial tachyarrhythmia, that is most probably atypical atrial flutter or non-CTI dependent atrial flutter. Going back to literature to try to understand not the mechanism where this atrial flutter originates. As we all know, atrial flutter is one of the interesting atrial arrhythmias, and there was a lot of publications about it, but the majority of the publications were about the CTI dependent atrial flutter, whether it's the electrophysiological properties or characteristics, as well as the electrophysiological properties. But the amount of literature about atypical atrial flutter is quite fewer than this. So when we revised literature to see this ECG, we saw there was one study that was that was back in 2003, studying the surface electrocardiographic characteristics of atypical atrial flutter, including right and left atrial flutter. And this series included only 26 patients with atypical right atrial and left atrial flutter, comparing the ECG of the flutter with what they found during the electrophysiological study, whether using conventional methods or 3D mapping mechanisms. And these patients, these types of ECGs, or this ECG pattern, was quite characteristics of patients with left atrial septal atrial flutter. That's atrial flutter circuit that originates or circulates or revolves around the left side of the interatrial septum with a sensitivity. And this ECG pattern had a very high sensitivity in diagnosing this type of atrial flutters, but the specificity was quite low, because other types of left atrial flutters, like the posterior wall scar circuits, showed also ECGs with these ECG pattern. So another study, the more recent study that was conducted by Marushi tal in that only studied this type of tachycardias, which are left septal atrial flutter, showed the same pattern of ECG during atrial flutter. But in this series that included only 11 patients with left septal atrial flutter, they could identify two re-entry circuits, or one circuit of left atrial flutter originating or revolving around the left atrial septal, but one circuit moving in the counterclockwise fashion, and shows this pattern of ECG with predominantly positive flutter waves in V1, and the rest of the leads show flat flutter waves. This was representative, or was representative of counterclockwise left septal atrial flutter, while the clockwise left septal atrial flutter showed the mirror image of this ECG. The flutter waves became negative in V1, and they are predominantly negative, and also the rest of the flutter waves in the rest of the leads was also flat. There was no significant morphology of flutter waves in the rest of the leads. So in this study, they showed two different ECG morphologies that are mirror image of each other. So at this point, we have a patient who has a history of palpitation. He has an incessant tachycardia that is highly symptomatic, and it seems to be macro-reentrant atrial tachycardia or atrial flutter originating from the left atrium. His echo showed a mildly dilated left ventricle with fair ejection fraction and dilated left atrium, denoting starting tachycardia-induced cardiomyopathy. His previous medical treatment showed great failure in controlling his symptoms and in controlling his tachycardia, but also complicated by bradyarrhythmia. So at this point, we were faced with only one solution for this patient, is to do an EP study, or mapping an RF ablation of this tachycardia, trying to study its mechanism and to localize the re-entry circuit using 3D electroanatomical mapping, and added to it to study the conductive system of this patient, to see if the AV block or the bradyarrhythmias of the AV block is drug-induced, or there is an intrinsic AV nodal disease or His-Purkinje disease. So we started our EP study. We did a transesophageal echo first, and it was free. And we did our procedure under general anesthesia. And our plan is to start with right atrial activation mapping first. We have to do an activation mapping of the right atrium first to make sure that this flutter or this tachycardia doesn't originate from the right atrium. And after confirmation of this, we move to the left atrial activation map. And despite that, we were planning to do a 3D electroanatomical mapping using CARTO system. I don't know, the mouse is not moving. Anyway, despite that, we were planning to do this map using 3D electroanatomical mapping system. We decided to use multiple multi-electrode catheters to record the intracardiac recording in the right atrium, more specifically just for interest to see the intracardiac recording. And as we can see that during the patient at the beginning of the study was in incessant tachycardia. The tachycardia didn't terminate all through the procedure. As we can see at the upper intracardiac recording, the tachycardia cycle length was about 268 milliseconds, and the activation of the coronary sinus was from proximal to distal. That made us think that this tachycardia made us exclude the idea of perimitral atrial flutter or perimitral atrial flutter. Then if we look carefully at the intracardiac electrogram from the right atrium, the first electrogram is coming from the His catheter, which is a quadripolar catheter. It was not exactly at the His position, but it was slightly at a septal, at a slightly lower position, more atrial, as it shows an fractionated atrial electrogram. And as we can see, the atrial electrogram at the His catheter is the earliest electrogram, and from which the activation of the right atrium moves in a centrifugal pattern, upwards up the septum and downwards, activating the coronary sinus and then activating the CTI and the lower right atrium, and then the waves of activation collide at mid-lateral right atrium. This indicates the centrifugal pattern of activation of the right atrium. This gives an idea that most probably the right atrial activation is a passive activation and the right atrium is not involved in the tachycardia of this patient. And the data that we got from the conventional or intracardiac electrograms recorded from the halo catheter and coronary sinus catheter were somehow confirmed by the activation map by the CAR2 system. As we can see here in this image, we can see here that this is the right atrial map. This is the tricuspid annulus, right atrial appendage, SVC, and the coronary sinus. And we could map the right atrial activation represented just roughly above more than 50% of the tachycardia cycle length. So this didn't confirm it was on the fence. It's not re-entrant, and also it's not focal. It's midway between. But if we look at the activation map of the right atrium, we can see that the earliest activation is at a discrete area at the lower posterior septum, close to the coronary sinus ostium, and from which the activation of the right atrium runs in a centrifugal pattern. This confirms also the passive activation of the right atrium. That means that the right atrium is not related to this tachycardia, and it's only passively activated from the left side. So at this point, we decided to go into the left atrium, and we did a transseptal puncture. Oh, sorry, before going into the left atrium, we wanted to confirm our finding by activation map that shows that the right atrium is passively activated. So we decided to do entrainment mapping from different sites at the right atrium. And these points or tag points indicate these different areas that we did entrainment mapping, from the coronary sinus ostium, from the posterior interatrial septum, and the CTI, and the lateral right atrium. This is intracardiac recording. The next is the right atrial, the intracardiac electrogram recording during entrainment mapping from different sites of the right atrium. Here we can see this is the intracardiac electrogram recording during entrainment mapping from the lateral right atrium, and we can see that we have a very long PPI. This is with manifest fusion. That indicates that the lateral wall is not related to the re-entry circuit. Also, entrainment from the CTI also showed a very long PPI, more than 30 milliseconds from the tachycardia cycle length. But when we entrained, interestingly, when we entrained from the His catheter, that I said it was in a septal position, but in a lower position than the His bundle region, and more towards the right atrial side, we can see that the intracardiac electrogram coming from this His catheter is somehow fractionated, and it precedes the flutter wave on the ECG. And when we entrained from this catheter, we can see that the PPI was not so much longer than the tachycardia cycle length. It's about within 10 milliseconds or less than 10 milliseconds from the tachycardia cycle length. So we could identify that we are closer to the re-entry circuit, that this position of his catheter is closer to the re-entry circuit, but actually it's not within the protected isthmus, because if we can see, we look at the intracardiac recording at the halo catheter during entrainment and during tachycardia, there was slight change, so there is manifest fusion. So this position at the septum is closer to the re-entry circuit, or maybe within the re-entry circuit, but it's not within the protected isthmus. So at this point, when we had very valuable information that the activation mapping of the right atrium gave us using conventional catheters and also 3D mapping, that the activation of the right atrium is passive activation, and the right atrium is not related to this tachycardia, and the tachycardia is most probably coming from the left atrium. So we went with transseptal puncture, and we started to do an activation map of the left atrium, as we can see here in this figure up there, and the activation map here. During activation map, we could map around 80% of the tachycardia cycle length. That suggests that it's a re-entrant tachycardia. And we saw that the area of the exit site is of the tachycardia is, or the earliest activation is at the anterior septum, close to the mitral annulus. To the mitral annulus is the site of the fossa ovalis, and then the activation of the left atrium goes in a circular fashion or circular pattern of activation, and a counterclockwise pattern revolving around the interatrial septum. And here we can see the propagation map of this tachycardia. It's very interesting propagation map. This is the anterior part of the septum on the left side, and we can see that the wavefront exits at this site, and then it circulates around the left atrium, or activates the left atrium in a circular fashion, and the circuit, it's a micro-enter circuit that revolved around the anterior part of the interatrial septum. So the activation mapping of the left atrium gave us an idea that this is a left atrial flutter, a left atrial flutter. So we wanted to confirm this by entrainment mapping from different sites of the left atrium, and also we wanted to use the entrainment mapping to localize the area of protected isthmus in this atrial flutter. So we did entrainment mapping from different positions, mainly in the around the mitral annulus, anteriorly and posteriorly, and the left atrial appendage. Also, we did entrainment mapping from the anterior interatrial septum, or near the fossa ovalis, and the posterior interatrial septum and the posterior wall. The majority of sites of entrainment showed very bad entrainment with very long PPI, except at the septum. When we entrained at the anterior septum, I'm trying to use my mouse here to show you where we, at the blue dot in the activation map here, this is the entrainment mapping. The lower panel shows the entrainment map, the upper panel shows the entrainment mapping from the posterior interatrial septum. If we look at the intracardiac electrogram coming from the ablation catheter, we can see it's very fractionated intracardiac electrogram that also precedes the flutter waves, and it's pre-systolic, or maybe near the exit, closer to the exit. And when we entrained from this position posteriorly at the septum, we can get a good PPI. It's a little bit longer, within 30 milliseconds from the tachycardia cycle length. And also there was some sort of a concealed fusion. There was not a manifest fusion. So we could identify this site as a part of the protected isthmus. But when we paced from the anterior part of the septum at the site of the blue dot here in the activation map, showing the lower panel, we could get a way better PPI. The PPI was identical to the tachycardia cycle length. There was entrainment with concealed fusion. There was no change in the intracardiac electrogram or the right atrial and left atrial activation sequence. And also the intracardiac electrogram from this site, or the ablation catheter, if we can notice that it's highly fractionated and it's almost mid-diastolic. That means that our catheter is right in the middle in the protected isthmus. that means that we are in the site of protected isthmus. And this is the propagation map of both maps, the right atrial and the left atrial map. We can see that the re-entry circuit evolving around the anterior part of the septum, or the ostium primum, with circular activation of the left atrium and passive activation of the right atrium. It's a very interesting map. So after confirming that we have a single macro entrance circuit revolving around the anterior part of the interatrial septum on the left side, which is known as the septum primum, or at the site of the fossa ovalis, and we could identify the protected isthmus at this part, we started ablation, and we planned our ablation. We tried to ablate, to start with linear ablation, starting at the area at the point where we had the best PPI or best entrainment. And interestingly, once we started our ablation, starting with our ablation lesion, first ablation lesion, the tachycardia terminated. We stayed in the cath lab for a whole 1 hour, and the patient was insistent tachycardia, and it didn't terminate all through the procedure except during RF ablation. With the first RF lesion, we could terminate the tachycardia, but we were planning to do a linear ablation. We took our lesion down to the mitral annulus to make a linear lesion. We extended also our lesion up there up to the closer to the left atrial appendage, and this is called as the anterior approach of ablation. And we decided to do the posterior approach also. We extended our ablation posteriorly at the from the blue dot here, or the area of the best, or the isthmus here, down backwards in the septum posteriorly towards the right inferior pulmonary vein. So we did both the anterior and posterior approach of ablation, and here is the ablation, our ablation lines as they show with the two maps, the right atrial and the left atrial map. And we once we start our ablation, we can see there is a clear termination of the tachycardia and return to sinus rhythm. So following our ablation, we started to do our post-ablation study, trying to re-induce the tachycardia, and we tried programmed electrical stimulation from different sides, from both right atrium and left atrium, especially at the left side of the septum, and there was failure, re-inducibility of the tachycardia, and that was our endpoint at this point, using drug provocation. And this is our ECG before, at the end of our study. Going back to literature, trying to understand this type of tachycardia, this is a unique type of tachycardia, and it's a rather rare type of atrial flutter. We must understand some anatomical and embryological considerations regarding the interatrial septum. During fetal growth, or the early weeks of embryonic development, we know that the atrium is a single atrium, and the interatrial septum starts at I think the 4th week or the 5th week by the septum primum. Which descends from the roof of the right atrium, right in the middle, and as it goes down there to join the endocardial cushion, to join the endocardial cushion that makes the AV valves, it starts to, as we see in here, I cannot find this. It starts to have fenestration at the roof of it. This is the ostium, this is the septum primum, and then becomes, there's a big gap in the roof or the upper part of the septum primum as it descends down there and communicates and with the endocardial cushion that forms the AV valve. Later on the right side of the septum primum, the septum secundum starts to form by enfolding of the atrial wall, and it starts to descend from the roof and ascend from the floor to close the gap to close the gap. But right at the 7th week of gestation, it stops to form what's called, as we can see here, and this diagram, the fossa ovalis. And the fossa ovalis, it's the gap between the septum secundum and the septum primum. So the septum primum is on the left side of the septum, and it's facing the left atrium, while the septum secundum is on the right side and is facing the right atrium, and the fossa ovalis is the gap between both. And the infolding of the septum secundum above the fossa ovalis is called as the limbus. And this, as we can see here in this anatomical or this specimen of the right atrium is open, and we can see the inferior vena cava and the fossa ovalis, which is the thinnest part of the septum, and above it with the black arrows, this is the limbus of the fossa ovalis, and this is the trapeze valve and the coronary sinus. So in the Marouche et al. Study that was conducted to study the left septal atria flutter, the electrophysiological characteristics, as well as the anatomy. They included, as I said before, 11 patients with left septal atria flutter and 11 autopsy heart specimens, trying to understand the anatomy of the interatrial septum and the structure of it and the muscular structure of it. And as I said before, they had some patients with counterclockwise flutter circuit around the septum primum or the interatrial septum, moving in counterclockwise fashion, and other circuits running in a clockwise fashion. If we look at their maps, if we look at their maps, the LEO maps, this is a clockwise atrial flutter moving in a clockwise fashion. We can see, we look at the the map down there in the left lateral map. If we look from the left lateral position, as if you are looking from the left superior pulmonary vein or the left-sided pulmonary vein into the right pulmonary vein, we can see the septum primum right in the middle. Anterior to it, there is a ridge. They identified a ridge of anatomical block with double potentials all through at the distance or the region, right in the middle, in the region between the septum primum and the right superior pulmonary vein. And they say that this ridge corresponds on the right side with the limbus of the fossa ovalis. And they could demonstrate concealed entrainment both anteriorly and posteriorly between the septum primum and the mitral annulus, and also posteriorly between this ridge and the septum primum. That's why they identified the approach for RF ablation into anterior approach and posterior approach. In some patients, they went for the anterior approach by extending a linear ablation from the septum primum to the mitral annulus, and the posterior approach extending the linear ablation from the septum primum to the anterior ridge, which is between the right pulmonary veins and the septum primum. And they found that the anterior approach was more effective in maintaining sinus rhythm or terminating atrial flutter in these patients. So going back to our patient, the patient was kept on oral anticoagulation for 3 months. There was no antiarrhythmic drugs prescribed due to the previous side effects of bradyarrhythmia. The patient remained in sinus rhythm till now. His Holter recording a month after the procedure showed no atrial arrhythmias and no bradyarrhythmias. So the take-home message here is that macro-oriented atrial tachycardias are divided into CTI dependent and non-CTI dependent, which are called as atypical atrial flutter. The CTI dependent flutters have been extensively studied using conventional or 3D mapping techniques. A few cases of atypical flutters have been reported, usually after surgical incision in the right atrium, and fewer data are about the left atrial flutter. Left atrial flutters are the rarest forms of atrial flutters. Left septal atrial flutter is a rare entity, and there are few reports about it, with distinctive ECG pattern. And the re-entry circuit usually revolves around the septum primum on the left side of the interatrial septum, and RF linear ablations lesions between the membranous septum and the mitral annulus seem to be very effective and safe therapy for this arrhythmia. Thank you.
Thank you very much, Dr. Rania, for this very interesting presentation, and very rare case, interesting case as well. And just for the sake of the time, I may ask Dr. Mohammed Magdi to give you his question about your case. And I'm sorry that it will be just one question from Dr. Mohammed Magdi and another one from any audience. If Professor Mervat have any input, of course, she can freely talk. Dr. Magdi?
Thank you, Dr. Rania. Very tough case, I think, in the cath lab. You stayed for quite some time during this procedure. My question for the sequence of activation, sorry, I got disconnected. I don't know how, but I reconnected again. And the CS, because in this flutter on the left atrium, I think the one that you presented, it's a counter, right?
Excuse me?
The flutter on the left atrium.
In the left atrium is a counterclockwise flutter,
exactly.
Yes.
But for the CS activation, the first one, it was proximal to distal, right?
It's proximal to distal, yes.
And on fluoroscopy, the CS location actually was covering this basal part of the around the mitral valve. So I think the activation should not be proximal to distal in this tachycardia. You should have an early activation, like 5-6 activation, breaking through CS1-2. And the earliest point should be around 5-6 or 3-4, not 9-10. For me, this is a little bit strange, the sequence of activation in the CS in correlation to the cartomap. You have explanation for this?
Well, I don't have an explanation to it, but I think it's not a problem to be for the coronary sinus to be activated from proximal to distal, because still the proximal CS is still septal, and the reentry circuit is septal, and the exit is at the lower septum, so it's close to the coronary sinus ostium. So I think it's logic for the activation of the coronary sinus starting from the proximal poles up to the distal poles.
Yeah, and if you ablate it, just imagine if this is like a perimitral, a typical atrial flutter, and you did just a flutter line from the mitral valve towards the head. You think this is just enough? Or you needed to ablate more posterior and the postroceptal region? I think according to this cartomap, if you just did one line from the mitral valve towards the appendage by withdrawing the catheter, this will also terminate the tachycardia, and you had a very nice potential covering more than 50% in the ablation catheter. This potential that you just showed us in the tracing, actually, this is one of the things that excite us during the procedure, because it's very fractionated, very nice potential, more than 50%. I have no doubt that tachycardia will terminate that site. Yeah, this one in with the round red circle. This is very interesting potential, covering more than 50% of the cycle. But I think it will be just more than enough to draw a line from the mitral valve to the appendage, as if you're ablating. It's like CTI of the left atrium. Let's call it something like this. But what's a little bit, for me, strange, the activation sequence in the CS is not matching the carto system. Whether the patient has some sort of block at this area causing this reversible sequence, I'm not sure. But sometimes we see such cases during atrial fibrillation ablation, sometimes post-atrial fibrillation ablation. And if you remember in 2006, Michel Hesseguer stepwise approach for atrial fibrillation ablation, starting by PVI isolation, followed by roof line, followed by mitral line. He used to do the mitral line as routine. This is 2006. Of course, after the STAR AFib study, we are not doing this anymore. But during 2006, Michel Hesseguer was doing this line for this target, for preventing future perimitral atrial flutter.
Yes.
Do you agree with me?
Yes.
So it's actually like a comment rather than a question, because
but I'm trying to find the question. I'm trying to remember the question. I didn't find the question. I think it's a comment. Yeah, but I guess you were asking if that. I think your comment that it was enough for me to do ablation, extending from the isthmus to the mitral annulus, and maybe extended upwards to the appendage, and that's it.
That's it.
That's what I understand. Well, I'll tell you what happened. Of course, this is the first time for me to ablate a left septal atrial flutter. I was convinced that the anterior approach is more than enough, and that's the place where I had the best entrainment mapping with concealed entrainment. But since it's the first time and you don't want to do less, you want to do more. So I combined the anterior approach with the posterior approach. But I think if I ever do or face another case with left atrial flutter again, I think I will be confined to one approach, and I think it's going to be the anterior approach, as you mentioned.